All right, we're going to go ahead and get started this morning for grand rounds. So I'm really excited to have Dr. Bindiya Bagga here. She's a former resident and did her medical training college at KMC in Mangalore, India, and did peds there, came and started residency here in 2005. Graduated in 2008, the Outstanding Resident Award for graduates. Went on to do pediatric infectious disease at St. Jude's, and then decided to stay in Memphis, and is currently an assistant professor of pediatrics at LeBonheur. She's also one of their associate program directors, and was just really a shining star while she was here. And then you can see from just the title slide, she's very busy, but also, it shows you where, coming from our program, she's just so well accomplished, and just in talking to people in Memphis, they're so thrilled to have her there. And so we're very excited about having her here. And so she's going to be talking about a really hot topic and something that's going to be very important for us, and that's antimicrobial stewardship. So Dr. Bindiya Bagga.
Thank you, Paul. That's very kind, and I'm really humbled and very happy to be here. And the reason for putting this self-serving slide is actually to show everybody how much you can accomplish. Even being from LSU. And I think the training that I got here sort of laid the stepping stone for all the things that I achieved. And I think one of the things that I learned here is to be decisive, be go-getter. And I see here a lot of mentors, and hopefully some of them will keep trickling in, but who are around at least in town. But really, that's the reason to encourage everybody that keep driving. I know that in residency you feel like it's never going to end, but it's just a stepping stone for some of us to move on to a lot of other things. So, all right, so bringing that to antimicrobial stewardship, I'm going to discuss just the basics, the concepts, introducing you all to it. I think this is a neat thing that ties together a lot of my interests, which a part of which, obviously a big part, is residency education, and hopefully trying to see if we could do projects together, sort of share things that I've done, and see if you guys could improvise on those things here at institution here. So with that, let's get started. So I have no disclosure, except I have one, which is personal, that I have the happiest of memories here. This is my one and only. He's the same child in both pictures. So you can see he's a happy guy in LSU, in Shreveport, never wanted to leave, and that's from his Shreveport Southfield School sort of activity, and that's him just computer happy. He still is computer happy, which I'm not very happy about, but what can you do? So great to be back. So with that, I'll go to some learning objectives. So the first big objective, obviously, is to understand the what and why of antimicrobial stewardship, just putting it simply. So the importance of antimicrobial stewardship, why is it there? Identify the national and local initiatives that are there across the country, and why are people so excited in this topic, and why are they so driven about this topic? And the second objective is how. So, okay, we're excited, how do we implement it? So that's the how, and what goals should you have for that? So that's implementing a pediatric antimicrobial stewardship program, and I'll share with you some things that we've done at our institution. And the third, and sort of an exciting part to me, is really how do you blend that into your scholarly interest, and how do you get residents and medical students to come in and join the enthusiasm, and sort of for us to sort of use their time and for them to use this for their scholarly output, and probably involve that in residency program with QI projects, and that's the one that I'm hoping to bring in, so can get Paul excited about that, hopefully. So designing evaluation strategies for your antimicrobial stewardship program that measures outcome and track progress and leads to publications and presentations, which I know we all want to have, those of us who are academically driven. So with that, going to the first big objectives, the concept. So really, it's not a new concept. It's something that's age-old. It's been there forever. So it's just a new name. to something that's been called antibiotic control before, it's been called antibiotic monitoring, it's been called antibiotic safety, and now the hot buzz is it's called stewardship, which some people like, some don't. What you don't want to call it is antibiotic police, because the people who do this are not that, so that's not the intention. So it really is basically just strategic efforts to optimize antimicrobial prescribing. So kind of simple enough, simplistically speaking, I like to think of it as rule of 5 R's. So right drug, right dose, right duration, right route, and the most important R is recognize when it is not needed. So all the 1 to 4 applies after the 5th one, So if it's not needed, stop it. So don't start antibiotics when they're not needed, and when they're there, just follow all the rules. So really at this point, you should be thinking, surely we are doing it right and don't need a program, right? If you're somebody like me who was given this to start as part of her job requirement when I joined as a faculty there, it's not something I was wanting to do. It just so kind of happened and fell in my lap. That's kind of what I thought, why do we need that? Surely after so many years of med school and training, everybody does it right? All right, so let's look at some data. So does this really happen, or is this an overrated cartoon? So think about this for a minute. I couldn't get the turning point stuff to work, so I'm just going to let you pause for a minute and try to answer this question mentally. And I may call out somebody. No, I won't, actually. So antibiotics are the most commonly prescribed therapeutic agents. So do you think it's true, false, or I don't know? I don't know. If there's a medical student here, the safe answer is C always, don't know.
I know the answer to that.
So we do, right? I guess if it's a stewardship lecture, the safe answer is true, because if I brought it up, this is like a leading question, you need to know the answer kind of thing. This not so much. This is sort of judging. This is something I was surprised by when I started looking at the data. US dollars spent on antimicrobials annually, what do you all think? 3 billion, 5 billion, 8 billion? Any guesses? 8. Go with the most. All right. So is this myth or reality? Are these numbers need to just show you facts, right? Why should you believe what I say? So this is where the facts are, right? So there's data out there that tells us that antimicrobials are really the most commonly prescribed therapeutic agents, administered 30 to 50% of hospitalized patients, and I'll show you some more data on that. More than $8 billion spent on anti-infectives in the country annually, and this is only rising because of new and more expensive drugs. So this is still old data, so we are way behind. This needs a new study. So and 200 to 300 million antimicrobials are prescribed annually, and about half of them are outpatient use, in case you were thinking that you don't need to know this if you're going to do primary care outside. So we all need to know this, so it's important data. So all right, so we are overusing. Well, surely that's an adult problem. Like always, that concept is good to have. It's probably not something we do. Pediatricians are always better stewards, right? Kind of in our mind. I don't know, I hope there's no adult audience, but that's fine. So this point prevalence study actually is very interesting. It's 1 day in winter and 1 day in summer. They looked at 29 NICUs and 35 PICUs in the country. And what they found from that point prevalence study is that 70% of PICU patients were receiving an antimicrobial, and these are the most common ones listed for you. And in the NICU, 43% were receiving an antimicrobial. And if you're in the NICU, you're more than likely to be receiving more than one antibiotic, and we kind of know the rationale for that. But really, there is pediatric data then to support this. And then this is looking at pediatric patients in hospitals such as LSU. So this is not looking at freestanding children. This is looking at children's hospital within an adult hospital, sort of the university hospital consortium, where all the data from similar hospitals are pooled like this. So and here too, they looked at the hospital discharges over a 7-year period and see what they found. That mean proportion of pediatric patients receiving at least one antibiotics is 33 plus minus 12. So if you kind of do the plus minus 12, it kind of, the plus adds up to nearly half of them. So approximately 500 days of antibiotic therapy per 1,000 days. So half the time that you're in the hospital, you're getting antibiotics. So a lot. Now this is looking at FIS data, which is what we use. So this is looking at freestanding children's hospital across the country. So, and here too, you could see, if you're looking, this is also an 8-year sort of study period, looking at a lot of admissions, and 60% of children during this time frame received at least one antibiotic. they also found in the study that there was large variation. So yes, we are using antibiotics a lot in the setting where you are in the setting where I am in. So kind of, globally, it's not where you are. We all are using a lot, all of us pediatricians. And then not only that, the study also pointed out that there's a lot of variation, so 38 to 72%. So kind of a lot of variation. So there's room for standardization, I think is also what the study points out. And then because you could have from 368 to 601 antibiotic days per patient days, according to the study. This didn't look at whether it was appropriate or not. So that's my next sort of concept. So okay, we said we are using a lot, but we are physicians, right? We should be using antibiotics. Antibiotics save life. They are like the best thing since bread and butter, right? So why do we want to not use antibiotics, especially coming from ID physicians? Why would me and John say stop antibiotics? We kind of work towards antibiotics. That's our sort of bread and butter practice, is to do that. And we'll be the first ones to say when it's not appropriate and stop using. So that always surprises some people, right? So are we using we're using a lot, but perhaps it's appropriate, should be your next concept at this point, or something that's crossing your mind, or at least it crossed my mind as I was, sort of looking these things up. So what do you think about this now? Antibiotic use is inappropriate, 30%, 50%, or 15%? How bad do you think we are? 50%. Imagine that. That's pretty, I think, that was humbling for me. I was like, wow, I'm kind of wrong as a med student half the time. That's not very nice. So 50% of the time, antibiotic use is inappropriate. And there's data, again, to back that up, so don't, and these slides will be available, I've sent it to Paul, so anyone who wants to look up and sort of, go and read these, some of these articles are very interesting and I think worth reading or discussing in Journal Club. So 50% of antimicrobial use is either unnecessary or inappropriate. 30% of anti-anaerobic use is inappropriate. And then I'll just point out here, a lot of people are on double anaerobic coverage a lot of times. At least there's things that we see a lot at St. Jude and LeBonheur, not as much as we used to before, but still being on meropenem and Clinda, for example, Clinda and metronidazole, and even if it's 1 or 2 days, it still adds up, right? 50% of VANC use in adult patient population and 35% in pediatric patient population, initial therapy is deemed to be inappropriate by these studies. So this point says, well, we're using a lot. We kind of learned that a lot of it is probably not that appropriate. But not only that, look at what we are using. So this actually shows, so if you see here, you've gone from cephalosporins, aminoglycoside, and you're going up now to, anyone knows what this is? Zola, can't pronounce it, and starts with an L, linezolid. So that's sort of something, our CVICU is very happy about and thinks it's better than vancomycin, so hopefully it won't catch on here. But look at the changes. So we are using a lot inappropriate. We're using more broad spectrum. So there's a big percentage change also in that. People are thinking that, not only should you use more, you should use broader guns. So that's not very good. So there's a percentage change in use of antimicrobial classes over the year. And this is still, plenty old data. So this is still all we have in terms of data, the most recent. All right, so we seem to be using a lot. Okay, so we are inappropriate half of the time. You could still be a non-believer. But so why care, right? So yes, I'm in Memphis. So does that mean I like drug dealing jokes? Maybe, maybe not. I don't know. I have plenty of people here who warn me about going to Memphis. It's a great place, guys. These activities don't happen, but it's just humor. So this is a drug dealer in terms of who gives out resistance, talking to Albert. Anyone knows who Albert is? Everyone knows who Fleming is, hopefully. Or if you don't, it's your lucky day, because you'll get to know Dr. Fleming today in the next slide. So Albert is actually, so Fleming should strike a bell with penicillin for some of us in the room. So he's, I won't say the guy, but he's the dude, no. He's the scientist who was primarily responsible for discovery of penicillin. And Albert is actually the Scottish policeman who was hurt by rose bushes and got a staph and strep infection. They don't know which one, way back. But he was given penicillin to try to cure it. And at that point, he died because they didn't, even though he was improving, they didn't have enough penicillin. So this is 1940s. And if you see the other one, the other slide is more of an encouragement slide for the residents. The first law of antibiotics is also the first law of residency, I think. That which does not destroy you, make you stronger. So if you've had a bad call, it's all good. I had to throw that in there. I always tell that to the residents. All right, so you will get stronger. So what happens? So antimicrobial resistance. We're leading up to inappropriate antibiotics and why should we care? So the first big thing you should care about is the development of resistance. So is that a new concept? Well, we try to discover most things, and I won't try to sell you, this is my new concept. Actually, Dr. Fleming, that's who this guy is, looking at the Petri dish where he discovered penicillin when he sort of plated Staph aureus and went out for, it seems, a holiday or something, and came back, and he had these areas where mold was growing, and where the mold was growing, the Staph aureus was not growing in the Petri dish. And that's how he discovered penicillin, that if you give the mold, you won't have the staph. So, neat concept, right? But to have that insight to see that. So even as he discovered this and got the Nobel Prize, this is excerpts from his speech. So he's talking about resistance back then. Even then, he talked about resistance, that they had actually demonstrated resistance in the lab, that, in very eloquent and British terms, I think, there is danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant. So really, probably one of the first stewards, I think. He also had some interesting facts and quotes, which I want to just share. So one was, when life gives you something you're not looking for, make use of it. So when life gives you mold, make penicillin. That hasn't happened very often, but look at this. He had a sense of humor too. And they also proved that he's very Scottish. Big believer in whiskey and wine on the side. I thought that was interesting. So sort of some trivia there. All right, so flash forward. So that was him, 1940s. Long ago, but not so long ago. We are not talking about the time of the ancient mummies. It's still pretty recent, right? So what he said actually was true. So this is penicillin, Staph aureus, 1944, a smarter Staph aureus, which is resistant now by 1962. You got methicillin, resistant, and then you have the bank stuff. So see how smart the bacteria is. So he was right, you introduce these, and this is best demonstrated in staph, and that's why I borrowed this CDC slide. And now we have obviously daptomycin and linezolid, so there's potential for developing resistance in that too. So resistance is not just true for Staph aureus, it is also true for other gram-positives. Enterococcus and pneumococcus both can develop resistance on exposure to antibiotics. It happens over time, but these have all been proven to have happened. So you could have VRE, which is a very, very common problem, at least in St. Jude. It used to be in our institution too. You could have pneumococcal resistance, which we've seen and we've dealt with, and that's the concept of giving the high dose for the ear infections that the AAP came forward with a couple of years ago. And it's really not true just for gram-positives, it's also true for gram-negatives. Now, you've heard of NEDM, that made my country of origin capital very infamous, New Delhi, metallo-beta-lactam sort of drug, the gram-negative that was linked to New Delhi. So really, carbapenem-resistant enterobacteria, carbapenem, we don't see that much of that. We have started seeing this a lot in our CF patients lately, and I don't know if you guys are seeing these, but it's a bigger problem in people who are starting with broad spectrum. So St. Jude sees this probably a bit more than we do, but it's still out there, more in the adult community. But if we don't practice what we're doing well now, this is, I think, going to hit pediatrics too. And this is just CDC data right there to show you that people are really concerned about this. So this slide is just to sort of hit home that bacteria are smart. You show them a drug and they will show you resistance. They are smarter than we are, and they are way ahead in showing. We may take years to develop a drug, but if you don't use it well, they can develop resistance pretty quickly. And I showed you that with penicillin, the time frame within 20 years of its usage, you have resistance. So 20 years of Mr. Albert dying from penicillin shortage, where he couldn't get penicillin, to 20 years later, penicillin can't treat staph. I think that's a pretty significant sort of event stream to hit that home. All right. So if you have resistant organism, well, so what? We can always have new drugs, right? So it's really, data says that the morbidity and mortality of multi-drug resistant organisms is pretty significant. It's related to increased virulence, delay in inappropriate therapy. You may have a resistant gram-negative and you may not know about it till your lab identifies. So you lose precious time. And we've had cases where, I remember a case of Stenotrophomonas that I was treating. In hindsight, maybe I should have started a different drug at the outset, because the kid developed this gram-negative bacteria while on cephalosporin and didn't need to be on this medication. So sometimes you don't know what you're treating, and that you lose the time. So that 48 hours could be crucial for that patient, and you may not be expecting a resistant organism, and it may just hit you in the face. So you could be in the NICU, like Dr. Pramanik, and you might be dealing with Candida parapsilosis instead of Candida albicans, and then you've already lost time by the time you get the culture results back, and you're just using fluconazole. So it's a concepts like that, right? So delay in appropriate therapy. Obviously, there are fewer treatment options because there's not enough drugs, and then they're less effective and more expensive therapy. So really a double whammy there. And then higher costs. So we're using more, we're going to use more expensive drugs, and the patient is going to stay in the hospital longer. So it all adds up, right? So it's pretty significant. The other very important thing that you kind of need to realize is that the implications of this is beyond the patient who's getting the antibiotics. So you may be spreading resistance to the community. So someone who's never actually seen an antibiotic may come with a resistant organism. And that's pretty significant. So you could change the ecology that we see, and we are seeing that too. Kids who've really not had antibiotic exposure, just by exposing the community, they could come in with resistant organism. So I think these are important concepts to have. And then the second big concept, I think, of overuse of antibiotics is C. diff. We all know about C. diff, and that's like a measurable bad outcome of antibiotic overuse that we like to hang our hats on. I think it's largely because we can measure it. And it's also in an adult patient population, it's got significant more mortality. I don't know that we see a lot of deaths. I've probably seen 2 in the 5-6 years that I've been there. And I don't know, John, have you seen many deaths with it? I've seen 1 at St. Jude and 1 at LeBonheur, so 1 healthy and 1 non-healthy host. But so the problem with C. diff is not that the drugs that you use to treat it is ineffective. The problem is that the patients are often, you are unable to remove the other antibiotic pressures. So they may be on other drugs too, and you're not able to remove that. So, and unless you remove that, you can't achieve cure. So that's the issue with C. diff. But there's really very clear data to say that with C. diff is really associated with broad spectrum antibiotics. So anyone amongst the residents here who can tell me which is the most common antibiotic associated with C. diff? What do you all think? Clindamycin, right? So I'm going to challenge that and say that that's true, partly, but not so much. So going to these APPD, sort of the ASP talks, stewardship talks recently, I've been astonished that we, not only clindamycin, now my routine thing is that even kids on cephalosporins, and we've done like a study in our hospital looking at drugs. So clinda is classically associated, but don't underestimate the power of cephalosporin, fluoroquinolones, and other drugs that you might be using in sort of making the patient get C. diff. So remember that too, it's not just the clinda. It's other drugs too, and there's data to say that all these antibiotics can, lead to C. diff. So clinda plus is what I like to think of. All right, so the third big consequence of inappropriate use, I think, is you're treating when you're not needing to treat, and the treatment is causing a bad effect to the patient. Well, that's really bad, right? Because then you're really liable for that, emotionally and professionally. So antibiotics account really for 1 in 5 drug-related adverse events, and more than 140,000 ED visits per year are due to adverse effects of antibiotics. So that's pretty darn significant. And about 50% of these are due to the penicillin cephalosporin group. And the other side effect that I want to hit home is fungal infections in NICU. So there's clear evidence saying that cephalosporin use and also meropenem or carbapenem use predisposes a NICU preemie to developing candidal infections. And I don't know what are the NICU candidal infection rates here, 0. Yeah, so, but in a lot of NICUs you do, so they're good stewards already here. But in a lot of NICUs, you do have this exposure, and we don't have that much high candidal load in our NICUs, especially in the birthing hospital, but at LeBonheur, so we have like a 232 bed like our children's hospital, and then we have a 70 bed NICU at the birthing hospital. So the birthing hospital stays clean, but the NICU that we have in our children's hospital gets everybody from outside, and they're the surgical patients and everything. So there we have more candida. And that's hard to control. So if you're working in a setting like that, they will be on broad spectrum because they're getting surgeries. So I think limiting that there is sort of the key too. So beyond that, I think, is also collateral damage. So this little child who's getting antibiotics, could be getting predisposed to what people say now is inflammatory bowel disease, diabetes, and obesity. And then there's fresh off the press data from PAS, which Dr. Pramanik might have looked at, which says that any antibiotic, even brief antibiotic exposure, even the 48 hours rule out sepsis antibiotic exposure really alters the gut microbiome, which is another hot topic that a lot of people are studying. So we are actually not doing a favor to these kids by giving them maybe antibiotics for maybe pneumonias, maybe not, maybe ear infections, because you're altering their future and their microbiome. So you're getting rid of their good bacteria, and that's never a good thing. The concern obviously is beyond antimicrobials. We won't go into details here, but there's anti-TB meds with resistance, anti-malaria drugs globally with resistance, all because of overuse, antivirals with resistance. I've treated one kid where we couldn't treat CMV infection with ganciclovir. We had to use phoscarnate. So you will occasionally be hit by these things. And then antifungal, like I was pointing out. And not to mention antibiotics that we are eating without knowing in our food. That's a huge topic altogether, for those of you all are interested. I think if you just Google antibiotics and veterinary use, you'll come up with a lot of hits. So things that we are exposed to without knowing. So really, snapshot, lots of resistant organism, and another snapshot. In contrast, look at the dwindling drugs that you're seeing here. So this is from 1980s, and this is 2012. So see this? There's not much. So drug development is dying out for whatever reason, and in contrast to that, you have the rising antimicrobial resistant organisms that you're seeing. All right. So people are saying now that we may be entering this post antibiotic era, where you may not be able to. You may go back to facing a patient like Albert, where you're not able to treat simple things like skin infections, and people can die of if it's a resistant organism, right? So that might be the future, that common things may be hard to treat. So you don't want to get to that era. So people like you who are getting out there and starting to practice, it's a good time to sort of start getting very astute about these things, because each one of us is responsible for globally making this event. Not one person, not John or me or Paul individually can do this. It has to be collective, right? So really, antimicrobial stewardship then is the rationale. So it's to conquer this drug-bug imbalance. It's to shepherd precious resources, to give the future generation drugs that they could be able to use. And I see Marlene walking in. Hey, Marlene. All right, so that brings me to guidelines. So all this concern, and I think everybody's convinced at this point, or should be, that overuse of antimicrobials is not a good thing. So not just we recognize it, but people smarter than us have recognized this before us. So this is just to show you all the timeline. of the development of guidelines. So as early as 1988, this was recognized, but I think 2007 was the big push from IDSA and both of our big academic society, the SHIA and IDSA, which kind of came up with very, very good guidelines. And I recommend anyone who's interested in this to sort of read this reference and look over this, but I'll go over some of this with you all. So after that, there was this huge influx of national initiatives and state initiatives, which if it hasn't hit you yet, it's going to hit you soon. So national level initiatives like CDC has lots of stuff on it that are great resources, so that's one. State level initiative in California, who's ahead of us in a lot of things, not always good things, also has, it's mandatory there apparently to have antimicrobial stewardship, so they kind of have a state law. You need to have stewardship in their hospitals. This is for Tennessee. We kind of have some, but we're catering more right now to the antibiotic overuse in animals, so we don't really have that much geared yet. And I was looking at LSU last night and Louisiana State, so really not much for you guys. There is something right now on antibiotic sensitivity that's there, but there's not much talk about the program, so there's certainly opportunities to lead this, for people who are interested. So regulatory requirement snapshot, there's currently no national regulatory requirement for ASPs in the US. It's only true for, they are required for California state since 2008 and for all VA facilities. So really those are the two that really have embraced this wholeheartedly. But it looks like it's coming. They're going to require all centers which, accept Medicare and Medicaid patients to have that. So there's work in place and there's things that are happening where it's going to be mandatory. And if you still are not convinced, and this is from Barack Obama, whether you like him or not, he does say that combating antibiotic resistant bacteria is a national security policy. So there is, a lot of push going on. So it's a nice sort of time to join this drive if you haven't already. So I hope at this point we have all been collectively convinced that it's important at least to recognize what people are doing out there and hopefully try to embrace some of this. So now, if you're like me, when I was starting this, I was like, yeah, I kind of am on board, but how do I do this? So at this point, you're looking at really the nuts and bolts. How do you develop an antimicrobial stewardship program? So this is now the how of my talk. So what should be your goal, right? So the goal really is what it should always be. It's not a newly invented goal for a physician. Your goal really is improve patient safety, improve clinical outcomes. These are goals we think of every day, right, when we're admitting. So really it's the same goal. Minimize unintended consequences of antimicrobial use. So really thinking of these goals in terms of the data that I've shown you. So I think not knowing how much you're harming, and then once you know that you're actually causing harm, then you may look at these differently. You're improving patient safety, you're looking at this child and how he might be affected by this antibiotic course down the line. So every time that you do this, you may have a viral infection, but maybe not, so I'll just give you a course of antibiotics. And every time you do this, it's collective for that child, right? It just adds up. So having that knowledge base and then viewing patient safety, not just looking in the immediate, but looking sort of universally, thinking of ecology. So I think that changes your perspective a little bit, or at least it did for me, and you become more committed to the cause. And then your secondary goals, obviously, is to reverse the burden of antibiotic resistance, and that actually is the hardest goal to achieve. And then decrease healthcare costs. You've seen how I listed that, like at the bottom. That really is something that would happen, but that's not your goal. If you needed antibiotics for, improving the patient's safety and patient's clinical outcomes, none of us are going to say stop it. You want to go all the way. I mean, we are living in a first world country where we have the resources. No one is telling don't use when you don't have to use. So I think that's important. So healthcare cost will happen because of the good things that you're doing for the patient, and that's how you need to think about it. So this just nicely is something that I always show, which just rounds it up for people who are very visual like me. So I think the red here is the main thing, and this has already been your goal. So I'm not telling you something you're not committed to. It's just in the context of what I've shown, the data I've shown you before. And the bottom is things that would just happen while you're doing that. So how do you do it? So it's a team effort, obviously, right? You cannot do it by yourself. John cannot do it by himself. He needs each one of you to be a good steward. So I think really the core program, though, in most places is run by at least two people. One is an infectious disease physician, and I've gone to meetings where sometimes they don't have one. So it could be a general pediatric physician who's an inpatient hospitalist, Marlene, for example, if she's interested. Paul could be the outpatient guy, or he has too much to do already, but whoever, is looking for stuff to do, or it could be one of the chiefs. I don't know, you could think of ways that you could improvise it. So, it has to be somebody who's at least interested in it. So when I say infectious disease physicians, there's not that many of us to go around, right? I know there's not that many of John to go around. And there's Dr. Bocchini, who's always going out. So between the two, they have their hands full. And the second big part is the clinical pharmacist. And then you have these collaborators with infection control and clinical microbiology lab. And you need the support of medical staff leadership and local providers. This is, I think, the big thing. You need leadership support. So you need institutional buy-in. And you need to make a business case. I think this is the big thing. So because anyone who's doing this first job and second job needs some protected time. So I think those are like the key elements, which is where most people sort of falter. We all have good intentions, but we may not have the time, right? And then obviously in institutions where it's possible, healthcare information technology, that's the big thing. So really all healthcare workers is what I like to think of. So if you look at the bubble of circles there, I have everybody listed, and the green small bubbles that I have, I kind of think of that as each one. So we are all stewards, right? In every place that we are seeing a patient, we need to be responsible as a steward. So it's collective, but led by the ASP that's in the center, which is led by two core members at least. So some core strategies, there's really two main core strategies. One is prospective audit of antimicrobial use with direct interaction and feedback. That means you're giving them some time, and then and I'll show you a schematic of how this can be done. That means you're letting them use what they want, and then after a timeout, you go back and look, and then you tell them what they can do better. So give them some time. And formulary restriction, and John was saying yesterday that for meropenem, call ID is something that, it's kind of hearsay, don't just use anything. And I remember that I'd never used meropenem before I actually went from here, or cefepime, so these were new drugs for me, going there. But people are using it, and eventually, if you're not cautious, it would be coming to you too. So that's formulary restriction and pre-authorization. So those are two, where in the front end, you just sort of stop people from using these medicines. And then there's a lot of supplemental activities that go along with it, which is prescriber education, guideline development, order form development, de-escalation, IV oral sort of switch, and things like that. So really the key, I think, is you need to select the strategy or strategies that fit your institutions. You don't have to do all of it and look at this and overwhelm and be like, oh my God, Bindiya said so many things, surely we don't have time to do all. Well, you don't need to do all. You could just pick one thing and start with that. So don't get overwhelmed by busy slides, just pick one. So that's why I'm showing the options that it could be done in many ways. So this is the front end, the first approach that I was saying. So physician writes the order for the restricted drug, order comes to pharmacy, where the pharmacist says it's restricted, and then there's a talk between ASP team and pharmacy, after which they decide whether to give it or not, and a lot of institutions have adopted this. The second one is the back end approach, where physician writes the order, antibiotic goes regardless of what you write, and later antibiotics are reviewed by the ASP team. And this is our approach, where we let them use what they want, and then we go and then tell them how they can do things better in certain situations. And these are certain criteria that I kind of have just listed. You could just pick one or two of those. But I'm going to go on and show you what we did and sort of talk briefly about outcome measures. So, when you're doing all these, I think it's also mindful to start thinking of what you want to measure, because it's very important, in academic medicine, and just as a physician who's interested in doing these things, is when you're starting to plan this, one of the things I've learned is even if you start small, it's okay. You need to be able to measure the improvement, because if you're doing things and you can't show a change, then you don't know if you're doing the right thing. So whatever work you put in the groundwork, I think that goes into it. So you may just do one thing. You may just say today, I think we can do the drug-bug mismatch thing. where we get all the cultures from microbiology. We're going to look at all the patients who have these cultures. There may be 10 to 20 positives, depending on how much you get positives. There's not that many positive cultures, we know, in today's day and age, so there may not be that many. And you just review charts of those, and you see which ones, what are they getting, and whether it's appropriate, whether there's room to narrow down. So this is a simple, easy thing to start, that you could assign a resident to do it for a month on research and see if it works. And if it does, then make that as something you want to do. So this is just one example, but there's many more. So it's important to measure outcomes, is my point here. And then the most easy outcome to measure, what I've found, is to measure cost reduction and to measure length of stay, whether that got affected. And possibly patient outcomes in terms of length of stay. It's very hard to measure that you're going to change the resistance. So if you have, like we now are dealing with linezolid resistant enterococcus, not in terms of getting diseases from that, but in terms of colonization. And we are thinking it'll blow up into a disease, so we're trying to catch it. So that, reversing that, we know is going to take us years. So if that is your goal, you can't achieve it. So you don't want to make that as one of your goals, something that's non-achievable. You can measure C. diff rates, and that's achievable, to demonstrate a reduction in that, especially in adult hospital setting that you have here, the collaboration. We don't see that much of C. diff infection, so it's hard for us to see that. We do see a lot of C. diff detection. All right, let's skip this and go to R. So this is LeBonheur in its full glory in the night. I don't think you've ever seen that. I like the night pictures. Doesn't mean I'm living in the night all the time, but I do sometimes live in the night. So I'll show you some strategies that we used, and sort of since its inception in 2011 when I joined this and we started the program, what we did. So first we looked at background data. So this is FIS data for those of you who haven't seen this before. So this is the collective children's hospital data that's accessible to anybody who is in a children's hospital that we can get. So we looked at this, and our thought was, well, we need to start stewardship. Let's find out what are we using more than other children's hospital, and you could do that with your university hospital consortium, so to see how you rank compared to others, because you may think you're doing great, but when you compare, you're maybe not. So we kind of didn't expect a little bit, but we did feel that we are doing more. So we were using more of meropenem, ceftriaxone, vancomycin, sort of more than our peers, as you can see here. So there was room, we felt, that where we could make a case for this with our institution and leadership and sort of start developing this. So with this basic information, what we did initially was just devote time to do review of cases. So what we did was we looked back just at daily cases in what we felt would be our hot areas of capturing broad spectrum antibiotic cases, which is our critical care units. So NICU, CVICU, and PICU is what we looked at. So Kelly, our astute pharmacist, who kind of leads this program with me, along with another ID person, Dr. Anand. So she looked mainly at what we were using in these particular critical care units, and we identified meropenem, peptazo, and cefepime as ones that we are using a lot, and we're using them inconsistently. So we felt like there was room to improve here. So these are the strategies that we implemented of the ones that I showed you. So we used guideline. So we felt like we wanted to educate, because people need to know what to use. You can't just tell them you're wrong, right? So we don't want to lose that aspect. We used some of cycling in the NICU, where we kind of considered amikacin from gentamicin. We use no restriction. We use some computer-assisted strategies. These are order set plans that they had that we modified, and then review and feedback strategies. So what we did initially is we met with physicians in East units. So we kind of had the concept of physician champions. So sort of share the love, right? Concept. You identify somebody who's already interested and is a good steward in your ICU, and you say, why don't you come on board? Tell me why you use these antibiotics for. And based on that, so Mark actually is our PICU steward, and based on what they tell us, we had guideline development, so common conditions that they felt they needed guidelines for, we used that, and then we started doing guideline retrospective audit. We gave them some time with just the guideline. So we gave them a couple of months to just embrace the guidelines, and once they did that, we felt like we'd given them enough time. We gave them feedback, went back and looked at their usage, and I'll show you some data on that. And then eventually we went back and we did prospective monitoring. So right now we are doing 48 hours out. We look at all cases on very broad spectrum antibiotics, and if we feel they're appropriate, we leave them. If we feel they're inappropriate, we actually go and call, and we write a note in the chart where we document, so that there's ownership from us too. So we feel like when our physicians like it better if we actually document what we say, so that shares the burden for them too. So these are, I'm just going to flash through these because this is just for you to know this is a way to develop this. So these are our NICU recommendations, our PICU recommendations, and you can see these are common things that everybody is saying. And then CVICU, which I know you don't have, but you still may have these patients in your ICU. All right, so this is then measuring outcomes like I was talking about. So because when you tell the physicians in certain units, do this, they want to know whether if they did this, are they doing it okay or did it work? So we went back and measured that. So this is our baseline data. And then 1 year after guideline implementation. So you can see reduction for each one of these. So basically, we had reduction even 6 months after guideline implementation, and then a sustained reduction 1 year out. And this again, this is unit specific. So the bars here are this is just showing compliance with guidelines in percentage wise. And then this is showing, early onset, late onset sepsis, and NEC, the 3 main conditions for our NICU. So as you can see, we're getting close to 100% compliance. And I'm going to say that if I have it panned out, it's dropping. So it's something that's ongoing. It didn't stay at 100%. So it did well, but it's something that needs constant work. But this is just one way to measure it. And this is looking at CVICU antibiotic days. And you can see here, our broad spectrum antibiotic days fell down, and even our total antibiotic days fell down. So while this is kind of an unintended but good consequence. We were targeting broad spectrum, but people knew we were watching. So this is sort of that Hawthorne watching effect. So, while we were watching, they were just cautious and they were being good steward, and they started using less antibiotics. So really the progress made so far for this part is overall antibiotic days and broad spectrum antibiotic days in the critical care units have decreased after guideline implementation. So guideline implementation, decreased inappropriate antibiotic use, eventually came to the point where core strategy of prospective audit and feedback was feasible. So we got our numbers down to the point where we could actually give them feedback on those couple of difficult cases. So just you saw what we did, which was just educate and develop guidelines, and then just let that be for a while, and then give them time by reinforcing the guidelines, talking to them like this on multiple occasions, and then eventually when the numbers became so small, we could actually do it on a daily monitoring basis. So that's sort of what we did. So our approach, and we've put this up for publication now, is our approach actually shows that unit-specific ASP physician, I think we share the credit with our physicians who are actually there in the champions, how including them and developing guidelines with them in the front end really saves time when you're in poor resource and you don't have the time to commit for that yourself. And also, once you have that education piece in place, then when people are convinced by seeing data that they did it less, but even with that, the length of stay, patient outcomes did not change, they are convinced. Everybody wants to do the right thing, but once they just, in the critical care units, are caught in the moment, right? Because when kids crash, it's hard to not blame it on an infection. But when the dust settles down, that's the time when you go back and want to change things. So that leads me to the last brief section, which is designing evaluation strategies. And I've tried to show you these throughout the talk so that you can get some ideas on how you could potentially do things here. But just to show you how much can be done in even brief times by involving multiple people. So this is one of our first talks, which was impact of an antibiotic stewardship program at a children's hospital, just analysis of antibiotic use and acquisition costs. So very simple. So we looked at purchasing data of LeBonheur, and this, you get it from wholesale database. It's not something you have to invent or keep looking for. They'll give it to you. You look at LeBonheur antibiotic usage obtained from FIS data. So that's also data waiting and for you to use it. So that's easy to get. And then we looked at this data during 3 periods, pre-intervention, intervention, and post-intervention. And then we looked at total antibiotic days, which was standardized to 1,000 patient days. to compare the antibiotic days and to also compare length of stay, which we felt was an outcome of was a good clinical outcome to go by. So what we found was pre-guideline, guideline, and post-guideline, there was an yearly purchase down by 70%. So overall, we had a 70%. So it pays for itself, right? So you could potentially hire somebody part-time to do this and to show your institution that if this has to be sustained, then you need somebody to be doing this. So making a business case, like I said, if you do something like this, potentially your institution might buy in. I know for us, they gave us more pharmacists, which is great. So now we could expand. We've taken them to ED, and we're kind of getting more people to do FTE versus previously it was me and Sandy splitting 0.5 FTE, and Kelly with a full time. Then they gave us, once they saw data, they gave us more people. So that's always good. So this is looking at monthly broad spectrum antibiotics days per 1,000 patient days, and you can see the pre to post has gone down significantly. And this is just showing the same thing with the timeline of really what we did, which is education, guideline implementation. So really, we are not going and nagging them all the time. I really haven't showed you any of prospective audit data because we haven't analyzed this yet. This is all from the education and guideline implementation data, having stewards in place. So really just that piece. So even with that, there's a reduction. This is looking at length of stay and discharges, and you can see here, we didn't have any bad outcomes that we could speak of, by doing all this. So no one died of meropenem shortage or cefepime shortage, in our institution. So really, overall patient length of stay and deaths at more than 48 hours have remained stable. Broad spectrum antibiotic purchases have decreased with guideline development and implementation. And then these are just purchase data that I won't go into. This is a second project to show you something very simple. This taking a syndromic approach. So this is something I did with a second year fellow who wanted to do ED, and Shelley, who's an MS4. So when the IDSA guidelines came out, we were like, well, we don't think we are using, we knew from our FIS data that we are using a lot of ceftriaxone, and we were like, we hadn't looked at that because we were targeting broad spectrum, so we were like, well, this is a good time to look at that. So let's look and see if we're actually using ampicillin. So I think everybody here is aware of this data, that we want to now use IDSA is endorsing ampicillin used for uncomplicated community-acquired pneumonia. So, and I think, I'm sure you guys are doing it too, and we felt like we were doing it too, except we were not. So, this is the difference between perception. We were like, surely we are this big freestanding Mid-South hospital and we are doing everything right. So this is sharing what we were doing totally wrong. So our hospital, we were actually doing 91% of our pneumonia cases were receiving ceftriaxone. So this is a big difference. We also were using more azithro, but we haven't addressed that yet. But look at our ampicillin. Poor ampicillin is just hanging out at 1%. So we felt, oh yes, we have room to improve. This calls for a good project. So before that, we looked at our susceptibilities to make sure we are not living in this area where we are seeing resistant strep pneumo, right? Because you can't just embrace guidelines because without looking at local data, right? You want to look at local data to make sure you can embrace it. So we really didn't feel that our penicillin, requires more of cephalosporin. We didn't have that much of resistance, and you can see here that we had our intermediates for both. It's 10% for penicillin and 10% almost for cephalosporin, 11%. So penicillin actually, you could argue, is better, almost over here. So what we did was we made these guidelines for community-acquired pneumonia, and we actually have cards that we give out to the residents, and it goes in their handbook also, so as part of that. So they can look at it everywhere because pneumonia is one of the most common admissions, and that's one of the things we can really intervene. So after that, we went back and looked at the data again, and we got, so this is our ceftriaxone going down, and this just talks about our amoxicillin going up. And we just looked at other antibiotics to make sure that we're not using more vancomycin, that are they using more broad spectrum because they're scared of us? So we felt like we needed to monitor those too. So those remained relatively stable, but we could see so this was a nice SSPR poster and a presentation actually for Peter. So you can see here again how this can incorporate, right? Now this is going on to be a QI project to make sure it's continuing. This is another project on incidence, severity, and treatment of C. diff infections in pediatric patient population. This is a pharmacy student project. Antibiotic use in children with bronchiolitis, reviewing that and to see how inappropriate that is. And actually the interesting part from this project, the bottom line was that we are under treating. So you might get surprising findings, which are interesting and good to know. So we actually found that our incidence is same as in other big hospitals for C. diff. We are not having more, but we really are under treating severe infections. We have a room to go up. So you could find those things too. And that's the information we are giving back. And this is, we are overusing antibiotics, which I think everybody is for bronchiolitis. I think everybody agrees to that, which we shouldn't. So, and then we have this, one of the NICU projects we did after we embraced guidelines. Our NICU had a lot of concern that, going to narrow spectrum with just VANC and GENT, these kids are so exposed, they are post-surgical and everything, and surely we are losing ground. So we went back and tried to validate. So we went back and looked at all the cultures that we had from the NICU to see if our current antibiotic recommendations had any gaps. So we really actually didn't find any. So, but it's good to go back and see, right, periodically. So that gave our NICU doctor some confidence on what we are doing, and then they embraced it more wholeheartedly. And this is just PharmD students. So this is educational stuff you can do out of it. How they viewed their experience. She got a poster out of this, which she presented. And this is just fresh off. I submitted actually yesterday, right after I came. This is our VRE, this is an incidental, so just looking at your microbiology and antibiogram and see resistant pattern changes over the year. This is one of those projects that just happened. We saw this year that we kind of had a sense that we're using more linezolid, so we actually implemented linezolid guidelines, which we were sending out to our ICUs. They have a lot of linezolid use, more than they did previously, because some people feel it's better than vancomycin in their heads, and there's a lot of anxiety with Bredman syndrome, sometimes for CF kids. So, those are, and people feel like people have renal failure when they have septic shock. Well, they should have renal failure, right? It's part of the shock. So it's hard to separate those out. So we, while we were seeing that, we looked at our antibiogram for this year, and we saw a lot of vancomycin-resistant Enterococcus, about 42%, and that just blew us off. So we just correlated. So this is simple thing. So all I did was looked at linezolid use over the year that I got from pharmacy data. I looked at VRE from our data that was there in the micro lab, looking at susceptibilities, and I got a nice thing out of it. But now I know this is something that I want to share with the community, because I'm sure other hospitals are seeing that, and this has led us to make guidelines and implement that. So simple things, that can lead to projects. So these are things we are doing. We're going to continue to audit very broad spectrum antibiotics that I told you. We have kind of moved on now to auditing other. So we've serially stepwise gone the way. Now we are doing third generation linezolid, moving to aminoglycoside. A big part of this are educational and research, how to incorporate it into the ID curriculum. All our residents have to do QI projects, and I teach the med students their third year PEDS ID curriculum, so I always try to recruit them. I call it recruiting because we need them to do projects, and they need us to sort of get academic activities. And then pharmacy people, our pharmacists are great resources. So those are infection prevention people. They all get involved with us. And then we are planning to take it to community and outpatient clinic. We now have a web page, as you can see, with all of us listed here, Sandy, me, and Kelly. So I think I want to conclude by saying the future is now for ASP. So hopefully in this 1 hour, I've been able to convince you and make you be optimistic and not go into, we don't have resources, we can't do this, we don't have time. So take small things and try to include it and make that into projects that are fruitful and things that you could get improved patient outcomes from and things that you could get scholarly output from. I think it's important to blend the two together. And then, so the future is now. It's our stand against resistant organism. It's an improved dollar bottom line that's important for each one of us taxpayers. And to achieve success, I think the important things are to tailor ASP to suit your institutional needs and resources. I think that's important. You can't get bogged down by doing everything that the largest institution with with the most resources has done. You need to have small goals and try to go the step. Get provider, leadership, and administration buy-in by showing them data. I'm happy to share all of mine. It's already there with Jessica, but I'm happy to share whatever else if you all need any. Measure outcomes, and then build on your data. And it's important to have scholarly and QI project that just adds to your enthusiasm and vibe, and that when you're presenting, it gives you a drive to go on. So these are my acknowledgements. Mentors and colleagues, obviously, past and present, who are in the room, who I hope I make proud. And I carry the LSU light with me all the way. And this is showing that there's room for improvement really in your state. This is antibiotic practicing policies, and the dark one shows its rates are not very good. And with that, the little boy, my son, is grown up now. So you saw his picture. He was to my waist, and this is him, last month. I know. Hard to get them to even take pictures with you now, right, Marlene? I know. All right. I want to end with that. Thank you all for having me. Yes.
So, do you also look for the hospital readmission rates from all those patients that you looked into CVICU and PICU? Did you have that variable to look whether all these patients you said like pretty much had the same length of stay?
Yeah, we did look at readmission, and most of the kids that we actually intervene on, they have a long hospital stay. So there's not a lot of readmission data because these are chronic kids. A lot of our NICU patients kind of stay there for maybe a couple of months because they have CV surgeries and all. But the ones that did have readmission data available on, that didn't alter. But great question. Yeah. So there was no change in readmission. It did not lead to increased readmission. Anyone else? Dr. Pramanik, no question? I'm disappointed. I either did very good or very bad. I'm going to go with very good. Thank you.
For your success. You were mentioning about a Canada incidence. Perhaps when you were a resident, we had high incidence because we are, as you know, NICU was very, very busy, overcrowded at the time, and a lot of antibiotic usage. So we were working, there are 2 papers published in Infectious Disease Journal with Sharon Rebel. I don't know if you know her. She's a professor at Emory and came to us as a CDC consultant. And we found resistant organisms with Canada. And we mentioned parazoosis. We did have an epidemic of parazoosis, as you know. And the reason for that is there was a nurse who used to come and touch the babies, and she had a dog. And it's an organism that causes external otitis. And the CDC files are very good in tracking down. In terms of Canada albicans, the source in our epidemic was that we were using in those days glycerin suppository, rectally. And she was so smart to watch the nurses and document that was the source when we were waiting babies. And then again they did the DNA, the plasmid analysis. So there are about 3 papers published. But since that time with our stewardship, it's gone way down, as you know, nationally or internationally. Today we know that we start antibiotics in all sick kids, but the important thing is how quickly you discontinue it with 24 to 40 hours maximum.
And that's the key.
Good bacteria, So the last comment I want to make is you mentioned about New Delhi. As I travel around the world, especially in developing countries, as you know, antibiotics are available over the counter. That's number 1 point. Number 2 point, people have to buy it themselves. We don't have insurance like here. So they are thinking inadequate. And the third point there is the drug salesmen are pushing these 3rd and 4th generation drugs, which become resistant very hard. So one, as you pointed out, one has to look at the antibiogram of your institution or of the patient to see whether it's sensitive or not.
All right, great comments. Thank you. All right, thank you.